So let me not take too much time and invite Dr. Eric Kitali to come here and tell us what are the functions of Got Homies and what is the current status of these Got Homies, the challenges, barriers in scaling up that they are meeting in their efforts. You are welcome, Dr. Eric Kitali.
Good afternoon. What a great afternoon with the great people, colleagues, and friends. And today I'm so happy. I have my two mamas, Dr. Chaula and Dr. Swila. I'm so happy today because all this journey we are together since 2012 to date. I'm going to take you through Got Homies, which is the EMR under primary health care. And at Tamisemi, we have one slogan, which is, when we say Got Homies, we say you respond by one system, one patient record. Got Homies, one system, one patient record. That is our path. That is our vision. We want to have one system at primary health care. And if you look at that statistics there, all these facilities must have one EMR. And that EMR is Got Homies. Can we show the slides on the screen, please? Whoever is dealing with that, please. Yeah, and one takeaway from this afternoon session is whenever you go to primary health care, Got Homies is our EMR. And I'm going to take you through quickly for around 20 minutes or less to know exactly what is happening at the primary health care. The landscape, as you are seeing at the chart there, the landscape of the primary health care in Tanzania, we have more than 7,000 facilities, which are dispensaries, health centers, and district hospitals. And all these, within these facilities, primary health care facilities, we work and we capacitate health care workers to ensure they are using digitalization. And digitalization means the EMR and other systems which are working in the whole health ecosystem. Again, we have several initiatives like the Primary Health Service Development Program. We do have the Community Health Funding and National Health Insurance Funding for health financing, maternal health and child health programs. And here we are not, we are taking on board the mMama and other digitalization program within maternal and child health program. And we have few challenges within that. One being the limited access to healthcare services. We know that Tanzania is huge. You take Uganda, Rwanda, Burundi, Kenya, the total sum Tanzania is larger than those. So the limited access to healthcare services is among the challenges we are facing: inadequate infrastructure, equipment and supplies, all issues of disparities, and the burden of communicable diseases. Those are the challenges which we are facing right now, but we do have some opportunities, including the investment in healthcare infrastructure equipment. We do have the capacity building programs to strengthen the workforce for healthcare, enhancing community engagement and digital health technologies. Now, all those opportunities, initiatives, and challenges are somehow touching the 6 WHO building blocks. And within the 6 WHO building block, we have the information technology. And today, I'm going to take you through the digitalization, the information technology. And in this case, we are going to niche on the EMR. And in this case, it's GoToMIS. Why digitalization? It's not digitization, it's digitalization because we are dealing with the whole ecosystem, including the people, the processes, the procedures, the acts, the policies and everything. So why? It's because of all that, and that is known fact. Every one of us here, we know all this one. When we do GoToMIS, you know, as I told you, we are going to cover more than 8,000 facilities across the country. So when we do development of GoToMIS, we are guided by several principles, including infrastructure, access in the infrastructure, various facilities, the dispensaries, other dispensaries are very remote. So we need to see how best we can come up with a system which can work across. And in this case, we have two versions of GoToMIS. GoToMIS for low resource settings, low resource in terms of the limited human resource, infrastructure, equipment, and we have the centralized GoToMIS for the higher level facilities like district hospitals. So when we do development, we are considering the infrastructure, we are considering the engagement of stakeholders. And here stakeholders means all beneficiaries, partners, academia, researchers, we include all of them. But also the compatibility. We have my friend and my sister Sultana here on the standard. We are ensuring we are compatible with international standards like FIRE, HL7, ICD-10, IPS, and SMART. Here, SMART, I don't mean the specific measurable, attainable, and all that, but SMART in this case, the WHO SMART guideline, it's whatever we are doing must be standard-based, machine-readable, adaptive, requirements-based, and testable. So whenever we do all this, we have to take in consideration of the compatibility and the standardization. Empowerment is part of it, and phased approach. Right now, we are about 25% of the country, of the facilities, so we are keep on moving, and we call upon all partners to work with us to move on to complete all the facilities. Again, advancement on the innovation and research, and we embrace on the global principles, but we do locally, and those guys who are experts who are building the GoToMIS are the local guys. So global principles and local practices, evaluation, confidentiality of data, expandable involvement, enhancement, and all that. Those are the key drivers which we are taking into consideration when we are building the GoToMIS. And the pillars. Patient must be at the center. And we are coming up with health wallet, personal wallet, whereby you can even have your profile, access your profile whenever you are to see whatever is happening with your health status. Also, SMS reminder. In GoToMIS right now, we can even remind patient whatever clinic, if you have any clinic around, you can remind you. So these are the pillars which, again, are driving us when we develop in GoToMIS. Efficiency, equitable access, and all that. We started this journey quite long, like 10 years ago, a decade ago. And again, we several experts and colleagues and friends, partners, were all this in this journey. And right this moment, we have centralized GoToMIS, one patient, one system, one patient, whereby we can do the referrals, you can access one system, various facility can access one system. So this is our journey, and it's very long, 10 years. Here we embrace on Kaizen principle, whereby we keep on improving every single day. We don't have pilotitis disease. I know some other facilities and institutions, they do have pilotitis. Pilotitis, you are keeping on piloting every single day. In Tamisemi and primary healthcare, we keep on improving every single day, Kaizen principle. That's why we are moving. We have currently, right this moment, on those facilities which are using Gotomi centralized, we do have 18 modules. The very new one is Neonatal Intensive Care Unit, NICU, and Kangaroo Mother Care is in Lushoto. Diabetes and hypertension is also new, and telemedicine, immunization and telemedicine. Those are very new, like a month ago or two, have been brought into Gotomi. So Gotomi's one system, one patient, this is what it means. We do have all the modules and services in one system across primary health care. Right this moment, the Gotomi's old version, we have some facility with version 2, version 3, and version 4, and some facility with version, centralized Gotomis. So those are the facilities, and again, we call upon different partners and friends and colleagues to see how best we can reach all the facilities, maybe around now and 2025. Success, this is the known fact. Once you do digitalization, you improve data accessibility, enhance care and coordination, and the increase of revenue. Some other facilities, the revenue increased by 10-folds, 5-folds, and all that. Yeah, we do have challenges. And again, all these panelists here are among key partners and stakeholders which are helping us to overcome all these challenges, including Ministry of Communication, Science and Technology, Ministry of Education. So these are the challenges which we are facing. And later down the slides, I will share with you how are we overcoming all these challenges. Case study. Korogwe Town Council Hospital and the Chalangwe Health Center. Korogwe, Gotomi centralized, started in 2023 October, and about 95% of the services are using centralized Gotomis. We trained more than 150 health workers, and the LAN has been installed across different points in the facility. So what you have seen in Korogwe, we have the centralized medical record. Right this moment, for instance, you can even access whatever information, tracer medicine, 10 diseases in a particular facility, in a particular district, in the country, in the region. You can just do it here at the central point. So the integration with medical record, medical equipment, is also done in Korogwe. And in Mtua, before we started this session, one of the director of hospital, regional referral hospital, asked about the integration between the EMR and Mtua and PEPMIS. Again, we are already integrated with Mtua, so there's no need for, once you are using Gotomis, to manual filling the Mtua forms. Rather, we can just get the information straight from Gotomis. As we all know, the revenue increased from 3 million to 8 million when we started using Gotomis centralized. So these are the case studies which are happening across different places, different facilities across the country. And here we have Korogwe, and we have also Chalangwe Health Center in Chunya. As I said, we have one system, one patient record, and we can access from Directorate of Health Services at Tamisemi. They can access different records, different information centralized at that level. So here we have information regarding different parameters and indicators. And we welcome you all. I have my colleague here where I see Mark Tanda is here. You can just stand up. He's the man again behind GoTomis. You can even contact him to see how best we can demonstrate what is happening in GoTomis. So we have all these reports. As I said, the tracer medicine, if you want maybe even expiry of medicines, the near expiry medicine, we can just have it in GoTomis. So this is what we can advocate, and we welcome every one of you to give a hand to ensure GoTomis is going across all the facilities. The benefits. It's a role-based. You cannot just access anything. Not every I want to use Tom and Jerry and Jackie. Can access everything? No. You have specific role. You access a certain record which you have been allowed. So these are the benefits. As the data integrity has been enhanced, we are audited by IGA, we are audited by CAG, we are audited by different ministries of health to ensure the privacy and confidentiality of data is as required. Those are the benefits of GoTomis, and right this moment you can just do it when at the central level. Another benefits, we have more challenges in integration because the system is centralized. The integration is quick and easy. What are we facing during the installation? Resistant to change, but how we do it to mitigate? We do the training and awareness. Interoperability issue, how we do it, we comply to standard and standard, WHO standard and the national standard. Data security, we ensure we come up with protection regulation and standards, including encryption mechanism. Integration with other existing workflow, we do it, and we are integrating with other systems, resource constraint, this is well known. And now with GoTomis, we have reduced around 50, 40, 30% of whatever which we are using during the previous systems. Future direction, quickly, we want to ensure GoTomis is sending data to national data repository. And when we say national, we mean health sector data repository. So we integrate with community going to GoTomis at the facility, we send data to DHIS, and my brother, Director Ilomo at the Ministry of Health can access the primary healthcare information, including for private and public. Enhancement integration, here we have all this, and again we call upon every one of us here to see how best we can shake hands and move together. The call, for really we need to come together for transformation in primary healthcare, and the most thing here is continuous improvement. Whatever you see there is a gap, we can work together to improve and fill that gap. Interoperability, data exchange, equity advocacy, everyone here is data hungry, and GoTomis is here to solve and respond to any data requirement which you have. Support. The structure of Tamisemi is super excellent in terms of support, because we do have RMOs and regional ICT officers, we do have DMOs and district ICT officers, we do have MOIs, we have all people at different levels. So the support is easy. We use video tutorial, we use field visit, we have the help desk, and right this moment we have a contact center whereby interact with the public, means the citizen. Whenever you go anywhere and you feel like you are not treated very well, you can just contact Tamisemi through contact center, and we do the needful. So those are the areas which we ensure whoever is using the GoTomis at that level, it gets the support. Thank you very much for your attention, and thank you very much for listening. Kazi endelee.
Thank you for the applause, and let me now welcome the panelists to give us more information with regards to their area of practice. And I'll start with Mrs. Wendy from UNICEF, who is going to tell us how does UNICEF perceives as their role in digital health, particularly when it comes to electronic medical records and advancing primary health care services. And since UNICEF actually is the brainchild for children's health, then I think she will have a focus on that. Welcome, Wendy.
Thank you very much. Can you all hear me? Eric, thanks for a great introduction, and thank you for inviting me to speak on this really exciting topic. An EMR has the potential to transform primary health care, but this can only happen if, as Dr. Magembe said yesterday, it is designed and implemented as a single EMR. And I think we've seen that here today, that is the concept around it. But it also needs to be used. And by used, I mean if it is rolled out and functional in every primary healthcare facility. If patient data is entered in real time by health workers. And if the information that's captured is used to inform decision-making and practice. And depending on who you are and what your role is, it can tell you about an individual patient. It can tell you in aggregate about the facility, or your district, or your region, or it can tell you about the nation as a whole. I've been asked, as you've heard, to illustrate some of this, especially in the context of children's well-being. So I'm going to use 3 specific examples from Tanzania in terms of what an EMR could do at scale. And the first example I'm going to use is zero-dose children. Zero-dose children are those children who have never been vaccinated, and they represent families who do not or cannot access health services, so they're very vulnerable. In 2023, Tanzania accumulated more than 1 million zero-dose children, and this presented a risk for vaccine-preventable disease outbreaks. In order to control this, the health system has to find these children, vaccinate them, and then increase their coverage over time to prevent further accumulation of these children. Now, in the absence of a scaled EMR, what the government had to do was they did an equity assessment. And what that is they tried to find out in general, who are these children and where can they be found? So are they girls or are they boys? Do they live in rural areas or urban areas? Are they hard to reach or easily accessible, and that kind of thing. From there, they deployed hundreds of thousands of community health workers to go door to door and try and find these zero-dose children, and then convince the parents to bring them in to be vaccinated. This was neither fast nor efficient, and it's still ongoing. Now, what we know from the TDHS is more than 80% of deliveries take place in facilities, and that's almost 2 million children who are born in facilities. A scaled EMR would immediately register all newborns. It would know where they live. It would be able to alert the health worker if a child missed their vaccination. It would be able to send a reminder to the parents to say it's time for you to bring the child for vaccination. And it would be able to refer defaulters to community health workers who could then go to that exact household and find that child, convince that parent to bring them to the health facility. And so you can see with a scaled EMR, zero-dose children could be a thing of the past. The second example I'd like to use is to highlight the provision of services for adolescents. We know that adolescents are some of the most difficult subpopulations to provide services for. But we've also learned what they need to have confidence and to seek health services. And what they need is time. They need to be seen right away. The provider needs to take time listening to them, counseling them, and the provider needs to take care in how they speak to them. But what we also know is healthcare workers don't have any time. Globally, we know that 1/3 of primary healthcare worker time is spent in record keeping and reporting. In Tanzania, there are something like 15 TUA books that a healthcare worker is responsible for maintaining and updating and aggregating. A scaled EMR that is used in real time would significantly reduce, and I think we've seen that in some of the case studies that you showed, Eric, would significantly reduce the time that health workers have to spend record keeping and recording, and then they could dedicate that time to providing quality services for adolescents in a friendly manner. The last example I want to give is on early warning and early action for public health emergencies. By capturing all information in a single EMR, emergent and unusual disease patterns can be detected early, because the EMR doesn't just collect information about predefined indicators. It collects all information. So even things you might not have thought you want to know about, it can alert you to some anomalies in data. And with that alert, you can take action quickly, but also, since everybody's registered in the EMR, you know how to trace them and to be able to respond quickly to that public health emergency. Digital health and EMRs are powerful tools, and they offer solutions to some difficult problems that we face providing primary healthcare services, including equity, quality, behavior change, and early detection of public health emergencies, just to name a few. Thank you very much.
Thank you, Wendy, for quite an elaborate explanation on how EMR can actually benefit children in terms of improving their health. Now let us hear from Silvano Silomo from Ministry of Health, who actually is going to tell us how does the ministry addresses patient involvement and privacy concerns that patients and relatives are likely to have, especially in the ongoing future implementation of digital health solutions using Good Homies. Welcome, please.
Thank you, moderator. Also, I'd like to thank you for having this opportunity to represent the Ministry of Health regarding with deployment of digital systems. I will tackle that concerning in two parts. First part, I'll talk about how do we do with the country framework on ensuring that data collected through this EMR are secured. But second, I'll go specifically to the sector, what we have done so far regarding to patient level data and how do we do to involve patient on making sure that they are securing their data. And the last part, I will make a touch with the aspect of infrastructure and how do we do together with the PORAG to make sure that all these concerns are taken care. So regarding with the country framework, what we did is Ministry of Health, PORAG, Ministry of Science and Technology, together we come up with a Personal Data Protection Act, which is coming into regulation as of May 2023. So this is one of the country initiatives that so far has been done to make sure we have some regulatory mechanism with regard to the EMR data which are collected. So what we did in the process of preparing this document, we make sure that we involve clients who are responsible, maybe collecting the data in different perspectives, to make sure that they understand this Data Protection Act, and they can be capable on being attentive on the data that has been collected through different digital systems. So in this PDPA, Personal Data Protection Act, we touch different aspects, like looking on how management of data collectors, how does the country act with these people who are collecting data at different perspectives, by make sure that they make registration on the type of data they are collecting, but also they have a right to collect the data that they want to collect, but also to make sure that procedures, whether they want to export data to the third part, they have to make sure that they are following proper procedures for exporting data to the third party. But also this PDPA, which is the Personal Data Protection Act, as the other side of set up, like if maybe complaint arise, how does this regulation act upon? So there are also a room for the clients who their data have been collected to enroll their complaints, to make some investigation with the complaint, but also to have a room to appeal if then the complaint or the investigation also, it can happen also. It's not a true complaint maybe, so we provide also a room to appeal. So these are PDPA, Personal Data Act Protection, is so far, it's a country regulatory framework. So after developing this country regulatory framework, we come up with a specific now. We as a sector now, Ministry of Health, together with the PRAG, trying to make sure that we make our regulatory mechanism focus to our, like this stuff of electronic medical record. So at the sector perspective, what we did is we developed a document which is called HIS guidelines, which if you will go through this HIS document, you will see how, if you want to access data from the ministry level, or if you want to access data at the primary health care, what you are supposed to do, or what are you supposed to go about, so that you can reach this point of accessing data. But also, it's not only accessing, even storage, dissemination, disclosing some client data, and even use. So we are trying to make sure that we consider all this, to make sure that these data, which are collected through our digital system, are safe. Also, a government set some infrastructure mechanism to make sure that even the data that are collected, they are stored here locally in the country. So through as an output from this PDPA, also we come up with the infrastructure set up like a national internet data center, where now we as a country are supposed to make sure that we are hosting our digital system in the country rather than hosting our system in a cloud. So we are not guaranteed with security when data has been hosted in the cloud. So here is some of what we did as a country to make sure that we secure and we involve patients through the data which are collected through the digital system. Thank you.
Thank you, Mr. Ilomo, for quite some detail on what the Ministry of Health is doing to try and work along the lines of the regulations when it comes to privacy and patients' involvement. Now let's hear directly now from Sultana Saif, who is going to tell us exactly what do they do in the EGA, Electronic Government Authority, to try and enforce these compliance issues of compliance to standards. Welcome, Sultana.
Thank you very much. First of all, I would like to briefly explain the overall roles of e-government authority. But before saying anything, can I please ask how many of us know or have heard about e-government authority? EGA, mamlaka ya serikali mtandao kwa Kiswahili.
Oh, almost all.
Wow, yeah, okay. Thank you. E-Government Authority is a public institution. It has been established under the E-Government Act number 10 of 2019. And through that act, we have been given a mandate to ensure the e-government initiative implemented in compliance to that act. So we are supposed to oversee the implementation of e-government related initiative. We are supposed to promote the e-government initiative. We are coordinating the implementation of e-government initiative. And above all, we are supposed to ensure we are enforcing compliance to e-government related policies, law, regulations, standard and guidelines. So as a mechanism to enforce compliance to e-government standard and guidelines, including Act and its regulation, we as e-government, we have developed a number of standard and guidelines that provide guidance on the implementation of any related e-government initiative. And those documents are publicly available through our authority website. So whoever intends to work with the government or whoever wants to develop a system that to be used in the government should ensure it's visit our website and go through the standard and guidelines. The documents are public, accessible, and they are free. And we have developed the standards and guidelines in respect to what the international standard and guidelines. So as a mechanism to enforce compliance to e-government, what we have done, there are many mechanisms that we have right now, but the main thing we have introduced a government ICT service portal as a single repository whereby all public institutions, in case you are intending to implement or develop any ICT related system, you are supposed to submit correct and complete detail in respect to what you are intending to do. So through that portal, every public institution is supposed to submit the details. And after submitting the details, we as e-government, we are reviewing the details and provide technical recommendation or technical guidance in order to ensure what is intended to be developed is adhering to legal and regulatory requirements. Another thing that we are usually do, we are performing regular checks. Or I can just say we are usually doing system audits or review and security assessment. The essence of doing the audits is to ensure how strictly the system comply or adhere to e-government standard and guideline. And in case there are any weaknesses that are uncovered, we are providing a technical guidance on how to fix those weaknesses. So same for GoThomis. GoThomis has been submitted in our portal, and we have thoroughly reviewed the system. And when we noted there are some non-compliance, we usually communicate with Director Kitali in order to ensure we are fixing those risks or threats that we have identified. So what I can say, we are working in collaborative with all public institutions, including PRLG, to ensure all systems that are developed or all systems that are used in the government are securely and they are effective for public service delivering. But another thing that we usually do is we are providing like technical trainings to ICT experts in the government to ensure they are in a good position, like to manage the system that they have in their institution. So we are equipping the ICT officers, like starting from development of the system, what need to be complied, what need to be adhered from the initial stages. Even when the system has been developed, in the deployment, there are some guidelines or rules that need to be adhered to ensure deployment is done in a way that no any compromise can be observed. But the other thing, where the system are hosted. According to the E-Government Act, all government systems are supposed to be hosted in the government-approved hosting environment. And we as e-government, we are providing a secure hosting environment for all government systems. So for the case of Good Homies, we are ensuring that the system is securely hosted, and whoever is supposed to access a certain information is the one who accesses. So there are access, identification of access level. If you are supposed to access, like you are supposed to approve maybe a lab result, you will only approve. Or if you are supposed to take testing for that, so the system will ensure that whoever is supposed to access a certain thing is the one who access. As far as patient privacy and safety is concerned. Thank you so much.
Thank you, Sultana, for your quite elaborate explanation on what does e-government is doing to ensure that standards are being followed. Now let's turn to the side of competencies. We know, all of us, that these issues of digitalization are not as simple as most of us might want to think. I recall in one of the sessions, somebody was talking about machine learning, and one of the participants asked, where will you get the money to buy the machines? These are the miracles and the difficulties when it comes to digital transformation. Things are going quite fast. And we really want to hear from our universities, and this we are going to hear from Felix, in terms of digital health competencies. How do you think it can be integrated into the training and development of healthcare professionals, especially and in particular making Good Homies effective at the primary healthcare level? Welcome, please.
Thank you very much, our moderator, Professor Simba, who is also my mentor. So the profile that he is providing, he's largely contributed to who am I in terms of understanding the health sector, but also the research component. So I'm also honored to be one of the panelists coming from the academia who are responsible, as he said, in building competencies, but also conducting research, whichever assessment we are supposed to do to inform decision making. Our keynote speaker has highlighted a number of areas that needs to be addressed to produce or to implement a meaningful EMR, electronic health records, electronic medical records, if it's used in different settings. And this is not only technology. He talked about the governance, leadership and governance, and one of the key components, WHO and ITU, the International Telecommunication Union, produced a guideline or a framework for National Digital Health Strategy, which has a number of components. And the key component, which is a foundation, is leadership and governance. And then the other aspects are around change and adoption. So digital transformation or implementation of an EMR like Good Homies, especially in a primary healthcare settings, which is in a low resource settings, like ours in Tanzania, it's not an easy undertaking as indicated. So it needs different competencies to achieve that. And number one, as per studies, is how do we have strong leadership and governance to really lead, plan, and lead this change. You have different components in play. The workforce be a key component of the change, especially. We did an assessment 3 years ago through data use partnership, and I can see Dr. Saif with Pat, together with the Ministry of Health and PRAJ, assessing curricula at the allied health institution, but also at the universities, and how friendly our medical and health allied sciences curriculum are friendly to digital health transformation, especially around the use of these technologies, computers, tablets, mobile phones, whatever digital devices that we use, but also data generated. So the findings shows that we more focus, of course, on data analysis, SPSS and the likes. And then the other area that we found is normal computer applications like Excel, Word, and the likes. And then areas of HMIS coming out from the new degree programs that have been implemented. Udom is one having undergraduate in health information system science. And then you have master's program in health informatics at UDSM. But the technology or digital transformation is rapidly changing, which means our curricula has to rapidly change to cope with the changes in technology. As you said, now we talk of emerging technologies. If you go and assess how are we preparing the users. So if you talk of the situation that we did, we are still far behind. Last year, WHO, in collaboration with stakeholders, produced what they called global digital health monitors, where countries report their digital health transformation status. Through that monitor, there are a number of components that are mentioned, as I said, around leadership and governance, strategy and investment as one of the key, policy, legislation, compliance, workforce aspect, standard interoperability, services and application that we are implementing, and areas around data use, but also more importantly, data governance, which include protection and privacy. We scored somehow from 1 to 5, in most of these areas we scored 4 on average, but in the workforce we scored 2. And that was purposely because the tool that is used by WHO is assessing 2 critical components. One is, do you have digital health related training programs for healthcare professionals and other stakeholders, be it in service or pre-service. And then number 2 is training of digital health professionals, the experts who will be leading this implementation. And also is the digital health cadre in the national scheme of service. So that's, you can see the score from 1 to 5, we scored 2. That means we don't have really adequately nationalized curricula for digital health professionals. But again, the digital health related in-service training, it's capacity building or competence-based development programs are not adequately in place. WHO is finalizing a digital health competency framework, which has, I think, 5 key components with number of modules in each component. One is you have the taxonomy of digital health solutions or intervention, where you have the health service users, or previously called the clients. They're using mobile apps, they're using appointment systems, SMS-based solutions. So they need to have competencies, one on digital literacy, ability to use these tools, but also ability to use digital health information that are generated from the system, especially when we are deploying different application programs for the clients. Indeed, the other component is for healthcare workers, which also includes community health workers. So there are a number of models around how they can use these gadgets, how can they use data from this system, including data entry, analysis, visualization, but also interpreting data to inform decision-making, be it in service delivery, but also in programming of health systems. The other layer is digital competencies for health managers. The managers are using various applications, especially for generating data, but also doing monitoring, supportive supervision. There are also models around this, and this is going to be published soon for the countries now to adopt into their pre-service training, but also in-service training. The other key players in our stakeholders are the leaders. The policymakers are also included to make sure they can set up policies, strategies, and investment to ensure GoToMIS is going to be sustained through local funding. So there are these models that we can use. And now we see the changing also professions in the cadres. In our global colleagues from the global north, they have clinical informatics, nursing informatics, public informatics. We need to produce these cadres to be able to support the digital transformation. And we usually call ICT to develop system for either nursing, for any service provision. And I can tell Shian, nurses and the like, they will say, you go and lock yourself somewhere, develop a solution for us. But we need to co-create. We need the requirements. Building a system is like building a house or an office or a government institutions. You need to have all the architecture documents developed by the professionals. They need to be approved. You need quantity, the BOQs to be approved, and all the journey until the building is inaugurated. So we need to work together through digital transformation journey, especially in implementing electronic medical record, which provides a 360 view of a health system, because you have all the health system building blocks implemented in electronic medical records or electronic health records. So let's work. It's a call for universities. Mohas is doing a bit, I can see my former Vice Chancellor is there. He has been instrumental in organizing Mohas Annual Digital Health and Innovation Week, which brings together to support, and Professor Simba has been the chair supporting us. But we have now established a digital health unit as an academic unit to provide trainings on digital health. And we are starting with a master's program in digital health to ensure we produce leaders who are competent in leading the journey, the digital health transformation journey, the programmers or system architects, but also the data commanders who are going to be able to manage the data, engineers of the data, architects of the data, and the users of this data to ensure we are providing evidence-based decision in health service delivery and health system management in general. Thank you very much, moderator.
Thank you, Felix. Thank you, Felix. And now, the last but not least, we are going to hear from the horse's mouth, because all the talk has been from the higher level. Now let's listen, because GoToMIS is being operated at the district and facility level. You are welcome, Dr. Darrison. You have 5 minutes,
Thank you so
please.
much. The pleasure is mine to have been invited to talk before you, and talking of the good news of GoToMIS. GoToMIS is playing a key role in improving the quality of care in the various aspects. If you think of improving the quality of care, health financing is the commodity we needed throughout the time and all weather. Every client comes at our disposal has to be registered in GoToMIS. If it's eligible to pay, has to be paying, and the records will be kept in GoToMIS. Now, having collecting money is paying from pockets, National Insurance Fund, ICHF, we have been able to run our facility throughout. But then again, if you have money, you have been paying incentives. From the time we started these meetings yesterday, there was the question to do with limited number of health task force. If you have limited number of staffs, the workload is just too high. If you want them to take too long, you have to get them incentives. And one of the incentives to everyone would be pleased of is a monetary incentive. GoToMIS is helping us in doing this. Then again, in health financing, If we have been able to run our facilities financially, we are able to have medicines and drugs in all the time. We are collecting them, and the electronic management in collecting funds has been able to minimize as it is possible that there is no one is getting out with money if everything is in records. You see? Now, being have solved out with financing, now learning the facilities is that easy. You can learn them without money. But I've been able to renovate, to keep our infrastructure. If you go to Charangwa, as Erika said, we managed to build the commodity farmer, the community farmers. As we speak right now, we are building the dental unit from cash collection, and Gotomis is doing the same. But then the other thing, with Gotomis, we are collecting data, but it has been helping us in data cleaning. You cannot plan without data. With Gotomis, we are getting the proper data. We'll be getting them at our disposal as early as possible. Rather than collecting about 12 mtua or 15 mtua in a cause like, for example, at OPD at Journalist Hospital, we are using mtua number 5. We'll book every week. Now think of 4 mtua books for 12 months for OPD during planning. You only need to access these data from Gotomis, and they're easily accessible. Now, speaking of Gotomis and improving quality of care, you can plan because you have data at your disposal. But the other thing, Gotomis is helping us to keep records of medicines. For the first time in the records, you can issue drugs from the stores to OPD, to wards, to theaters, even to RCH, even monitoring vaccines. We are doing the same with Mtua. Gotomis. Now, without Gotomis, the quality of care, yes, but again, it's not kept that properly as it would be with Gotomis. Gotomis is the cornerstone in building health system. Thank you so much.
Thank you very much, Darrison, for telling us what's happening at the facility and district level. Now, the floor is open to the audience for anyone who has questions. We'll be picking your questions and the discussants will respond after 3-4 questions. You are welcome. I can see a hand there. Mike, please.
Good afternoon, everyone.
Good afternoon.
Yeah, I would like to understand how comes then to the Got Home you cannot find Mtuha Book 5 data from there, because the clinician use Got Homes the same time Mtuha Book 5. The two things, end of the day you find the clerkship is poor. Even the medical report from the previous patient, you cannot find it. This area, you know, it's a cornerstone of but it's not there. So I think you can explain in that and how you can associate it.
Thank you for a good question. Just give it to the next person there.
Good afternoon. My name is Dr. Jacqueline Mosha from MDH. My question goes to the panelists, just to learn on how are we going to scale up the use of Gotomis at our CTCs, the care and treatment clinics, because we are missing that in the clinics, and with the ongoing call for integration of NCD to HIV, we find that there's some data that we miss, and when we want to integrate, we need to do referral of clients from CTC again to the OPD, so there's movement of clients from one area to another, and the full integration that we are talking about is not really implemented. Thank you.
Thank you, Mosha. Please, there's a hand here.
Good afternoon. My name is Nsia Kipiliango. I'm a digital health consultant. I would like to congratulate all the panelists and the presenter for a great presentation. And for me, it's just an observation. As we know, we are moving towards the UHC, and systems. And right now we are talking about GoToMIS and other systems that the government is currently using. And we said one patient, one record. So if I'm a patient and I move to private facility, and most of us here are doing that, that means my data can't be accessed anywhere. So let's think about how we can incorporate private sector records. And as we know, we have so many polyclinics, yeah, and they are all at the PHC level. So let's put that in our mind as we are moving towards UHC. Thank you.
Thank you for a nice comment. There's a hand there. Oh, let me shift now from the, yeah, please.
Okay, thank you. My name is Omari Bugui. I'm an assistant director of NCD from Ministry of Health. One is just experience from the gurus on the front. Have we ever did any analysis to find out why most of our people are lagging behind when we come to introduction of EMRs in most of our facilities? We have seen evolution probably on WhatsApp and many of social media. People are very much eager to start using those social media, but when it comes to EMR, people are lagging behind. The second one is on the pace that we see at the moment. There's a low uptake from the government side, or it is we are failing from the technological perspective of it, because most of the EMR that we are using are more than 10, 15 years old, but we are still lagging behind on failing to go into web-based. We have started PEPMIS almost 2 months ago, and it's gone all over the countries and all of us on our own website. But we are failing or lagging behind with the EMRs. So is it a problem with the government or us as a technocrats that we are failing to take it into the web?
Thank you. There's a hand here. And then there. Here.
Okay. Here. Thank you very much,
Dr. Mtei.
Yes, for the very nice presentation. Actually, in GoToMIS, you have been using the 6 WHO's building blocks. Community health. Actually, the improved WHO blocks has 7. Why are we not using the 7 blocks? That include community advocacy, community sensitization, and mobilization. Since now we are going for PHC at community level. Another thing is, this goes to UNICEF. We are talking about 1 million zero-dose children. And we are talking about 80% health facility delivery. But we have about 95% antenatal clinic attendances. Why the discrepancy? And are we really collaborating with TBS, because the growth rate is 3%, 2.9%. That would make deliveries at around 1.8 million per year. How come that we have 1 million zero-dose cases to be between 3 years and 10 years to get to that level? There must be something wrong somewhere. Another thing is on EGA, being a government-related digital platform, the relevant government digital platforms as a mandatory precondition for a system. Question number 4. The training curriculum actually is starting at higher adult institutions of learning. Don't you think, actually this would have been a question to the Minister of Education, don't you think it was high time that we started training our pupils from kindergarten rather than waiting until one is about to achieve a degree and so forth, is an adult, and then you are teaching him what is a computer? Kenya and Rwanda have started. They have laptops at primary schools. Don't you think that Gotomis actually transformation or something. Was there a contribution from much?
My name is Rashid, an independent M&E consultant. My question is to panelists, and my question is centered around, I would really wish to understand what is like a government approach in terms of like showcasing impact of these digital innovations. Because I understand as much as we do this innovation and move into digital transformation, there's an importance of showcasing evidence that this effort will really bring changes. Because we have seen like evidence on like similar initiatives. I can cite example, the Mama Namona program for UNICEF. If they do good M&E, and then we can really say like this initiative bring changes to our healthcare system, and then we might attract government attention to invest more and development partner to scale this initiative across different levels of healthcare system in Tanzania.
Did you get that? Good. There was a hand, where? Yeah, here. We will have time to finish. Let's hear him, and then we finalize with Dr. Bangi.
Thank you. Thank you very much. In regard with the interoperability and the data exchange, how far have you gone in Gotomis in terms of data exchange between among the facilities? Thank you.
Thank you. And that brings us to 11 questions, which I think my panelists will be able to address them very briefly, because I've been given an alarm that we are remaining with very few minutes. Is it really burning that if I don't allow you, you are going to go away crying? Okay, let's have the last question from here. And please be brief.
Good afternoon, everyone. I would like to congratulate all of you for your great presentation. I am Rose Kangwile, a health informatics graduate from the University of Dodoma. My question is direct to the Minister of Health and PLRG as policymakers. There is a cry as digital health professionals are being produced from the university, and you encourage us to take chances in digital space, but what's your goal, what's your direction in incorporating us in the working scheme? Thank you.
Yeah. Thank you. I think that will also involve Sukums. I think we have now quite a handful number of questions, 12. So who is going to start? I think you should be the last from the horse's mouth. Let's start with Eric. And as I told you, we have been alarmed. It was 10 minutes, now we have only 5 minutes. So 1 minute each.
Thank you, Prof.
Yes.
Let me go to Jacqueline. You'll go from to her.
A bit louder, please.
Yeah, let me go to
Good.
Jacqueline, the CTC and HIV. Actually, we are working on inclusion of CTC HIV into Gotomis, and soon we'll be ready, including the NCD and NTD. As I said, one system, one patient record. We are making sure we have one-stop center for all health record and health information within Gotomis. And say one patient, one record, public more, we have to see how best we can work on that. But right this moment, we have the HIM as the mediator, health information mediator and Muungano, and HIM has integrated different various systems, public and private. So within that, we can see how best we can, the referrals system, the whole ecosystem can take in on board the public and private sector. into the WHO building blocks, but for sure we are integrating the community health systems. We do have something called UHC, Universal Community System. The advocacy and community part of the WHO building blocks are part and parcel of whatever we are doing in the health ecosystem space. Contribution of KEC. Actually, we started with KEC back then 2012 when we were using 4Pay for revenue collection. And we moved to Gotomis 2015, we were with KEC and Mzumbe University. So much have been improved with us, the local experts within the government and private to see to where the Gotomis is. The MO said it very well. We do have much value addition when we are using Gotomis. First, as we said, the referral system. We have all the modules in Gotomis. The revenue has been increased. We can track the medicine. Even the productivity, we can just track that one. In government, we have PEPMIS, Public Employee Management Information System, as OPRAS, our scorecard. That part can be also tracked in Gotomis as part of productivity within health sector and within the health workforce. Thank you very much.
Thank you, Felix. Very briefly, and you may not necessarily repeat what Eric has responded to. Especially, he responded very effectively. That's why I started with him.
Okay, thank you very much.
Go on, please.
I think that there was one question around why is the health sector lagging behind in adopting digital health solution. Studies have shown that health sector, due to the health system complexity, has been among the sector that is lagging behind globally in adopting health information systems, especially the digital ones, partly because of the complexity, lots of processes that are involved, and they are not harmonized. Currently the Ministry of Health and BRH, they were harmonizing the business process even at the regional referral hospitals. So implementing a solution in such settings where the workflows are not harmonized, it's a challenge. So that has been, and the investment that is required, especially when you are doing implementation in a decentralized manner. Now the centralized system like PEPMIS and now centralized Gotomis facilitates the rollout of the system, unlike when you are deploying it in a standalone nature. The competency, I couldn't agree more that we need to build competencies from the kindergarten level. I know, I'm not the spokesperson from the Ministry of Education, but I know there is ICT policy in primary education, and they are working on implementing such with computer labs, with, they are now the teachers for Tehama, ICT. At least that will build them so that at the university level, we don't teach them computer application, Excel, Words, keyboard, and the likes, but we will focus on the digital solutions like Gotomis and other systems. Asante sana.
I think you need to also touch on universities. How are you involving them? The UDOM lady is worried that she may not get employment once she finished, and she's seeing opportunity there. Can you impress upon her?
I think what she was talking about is about absorption of healthcare, digital health professionals as a cadre, and that's what I discussed initially, that we need this to be a cadre. And I know there are efforts that in discussion with MOH, maybe Elomo can talk. We had this discussion in our Tanzania Health Informatics Association meeting, and that has been taken that we need to start talking to the President Office, Public Service Management, to have digital health cadre as one of the important cadre, and they need to take oath because they are really managing sensitive data. As much as we are talking of health data governance, with AI, machine learning, data is the gold, it's the currency, whatever you can tell, the precise resource. So these colleagues who are managing these data sets, these minerals, we need to take them as an important component of the health workforce or human resource for health.
Thank you. Sultana, please respond to the integration. Is it mandatory?
Yeah, I can say partly it is mandatory to integrate your system in case it has some connection with other existing government system. And like I noted before, I told you we as a government, we are reviewing the system, and in case we see this system should be integrated with another system, maybe in the health sector or across the government, we usually advise you are supposed to establish the integration requirement from the initial stages when you are developing a system. And right now, e-government authority has developed the interoperability framework, standard and guidelines, which can direct you how to establish the integration requirements. So whenever you develop a system, you first need to ensure the technology that you are using in developing that system must be compatible and flexible to be integrated with any other technology or with any other system that is using around the government. Thank you.
Thank you. For the sake of time, Ilomo will be the last. Let's take Erasmus. Wendy, please respond to the 1 million zero dose. Wendy, yes.
I think since this is not specific to digital health and to the EMR, perhaps we could take that question offline to give the other respondents more time.
Okay. Let's finish with Darrison.
Thank you.
Mtuha
number 5.
Got homies. Why?
Mtuha number 5 is there. It has been there since Got Homies version 1, version 2, version 3, and today is available in Live Got Homies. Then the other question was the exchange of patients' information between facilities. Now it is possible in Live Got Homies. Thank you so much.
Thank you. Ilomo, please.
Maybe a bit, moderator, regarding with incorporation
1 minute.
of graduates in a digital space. Basically, Ministry of Health has established the Center for Digital Health, where innovators. So the door is open, and we are welcome academicians, students, so we can sit together and get some experience again to digital health. Thank you.
Good. Anyone want to respond about the 1 million doses? Even in the audience, why are we having such a huge number? It's not. Can you give mic to, hello? No. No one has an answer. Okay.
Sorry, do you want me to respond to that?
Pardon?
You're talking about the question?
You want to respond to that?
I can. I just think that we were out of time, so I could respond to it offline here.
Okay, please.
Yes.
Okay. You can. The floor is yours.
Great. I think it's an accumulation of 1 million children since 2019.
Okay.
So every year there have been a certain number of zero-dose children. During the COVID years, this spiked, and we had much higher numbers, and we couldn't reach them because of COVID. So now, by 2023, they were 1 million.
So it
it's
is
not 1
cumulative,
million every year.
not annual. Thank you. Let me take this opportunity to thank our presenters, especially the keynoter and the panelists, for giving a quite good discussion of the topic. And thank you, audience, for coming, and also for putting up quite good questions. Unfortunately, we couldn't answer them in detail, given the challenge we had, the challenge of time. I was asking myself, who is me to tell the presenter who has been brought from Dar es Salaam, from Chunya, to come and talk about this topic, and I tell him, don't talk. So let's give them a round of applause for their good work and coming here. Thank you, thank you, thank you, thank you very much. Take home message, there's a lot that is happening in as far as digital health is concerned, that is targeted to patients' health at the facilities and also to the operations when it comes to management of the facility, especially financing. And working, we do believe that you have acquired quite some exposure to knowledge. You will be good collaborators when you go back to your offices and do something at least to make sure that digital health goes where it is wanted most, and that is at the primary healthcare facilities. Thank you very much, and you are welcome. Thank you, Wendy. Ndio unaingia? Safi sana. Kumbe ulikuwa umekaa pale unajiuliza utaondoka saa ngapi?
Hello, everyone. Hello. Can we stand up for 2 minutes, at least for the blood to move and prevention of NCDs? You can say hi to your neighbor. Okay, can we have our seats, please? Some they are taking good photos there with the former PS. Okay, can we start, please? Now, we are going for a very important session. And this is essential emergency and critical care in Tanzania. In Swahili, huduma msingi na tiba okovu kwa wagonjwa mahututi. It is significant that we are holding this symposium on essential emergency and critical care at this international primary health care conference in Tanzania. The current situation is that there is great need for emergency and critical care in our country. There is much evidence that most of the people, they are losing their life because they are missing the life-saving care. And mostly we know to the mothers, newborns, those who are having trauma, and the post-surgical patients. Critical care patients needs quality, emergency, and critical care. In the recent pandemic, as all of us remember the COVID-19, critical care was at the forefront of policy, and there was global and national realization that improving emergency and critical care can save populations at impact and is necessary in primary health care. The most essential and fundamental care should be prioritized first. especially in primary healthcare facilities. ECC in Tanzania is a new program, as you are going to hear during the presentations, and has a great potential in this country. We'll hear about it today. It will improve care and contribute to new knowledge in improving primary health care, improving maternal, newborn, and child health, but as well all other patients who have critical illness. On top of that, it will develop resilience for public health emergencies. Now, after that short introduction, I would like to introduce the keynote speaker, who should come forward, Dr. Karima Harid. Dr. Karima is a lecturer and a consultant at Muhimbili University of Health and Allied Sciences, and the experience of more than 10 years in anesthesia and critical care. Her expertise spans both from clinical and non-clinical aspects of healthcare, with particular focus on capacity building for anesthesia and critical care. She has contributed to research, implementation projects, and the policy development, enhanced care for critically ill patients. And in the EECC project, include the one for Tanzania, Dr. Karima stands at the forefront of advancing critical care in this country. She's dedicated to making lasting impact on anesthesia and the critical care, expecting exceptional care for patients in need of clinical care. Karibu sana, Daktari. Then we have panelists. First, Dr. Erasto Silvanus, who is an emergency physician graduated from Muhimbili University of Health and Allied Sciences in Master of Medicine in Emergency Medicine. He leads Tanzanian Emergency Medical Services Section at the Ministry of Health, has experience of 11 years, and is specialized in emergency care, point of care, ultrasound, ECG interpretations, and intensive care. He drives the national strategies including scaling up EECC, medical oxygen plans, as well as oxygen therapy manuals showcasing dedication to enhance critical care and the emergency services in this country. Karibu, Silvanus. Nice to see you again. Then another panelist, Dr. Albert Fadrun, is a senior lecturer at Muhimbili University of Health Sciences and a medical specialist of obstetrics and gynecology, with 14 years experience in Tanzania tertiary, district, and the private hospitals. He's a master trainer in the public health interventions, he's maternal, neonatal, adolescent, and child health, and master trainer for EXACOX, and this is East Central Southern Africa College of Obstetrics and Gynecology. She has a doctorate from Karolinska Institute, including, and she's working on quality of care, which is so important to us to ensure that we don't go into critical illness, but also is involved in medical education, HIV, maternal nutrition, health systems, preterm birth, and so forth and so forth. Karibu, Dr. Fadrun. Now, we have Dr. Ernest Kyungu. Karibu, Dr. Ernest. Dr. Ernest Kyungu is a public health specialist with more than 22 years of working in the public and the private sector. He has worked as a DMO in several municipal and district councils in Tanzania for more than 15 years. Currently is working at the PORAJ, coordinating emergency preparedness and response, including outbreaks, preparedness and response. Also, he coordinates NTD's control program. Karibu sana, Ernest. Then, it's my colleague and a friend, Dr. Mwandalima Isihaka, who has a background in medical training and specialized in community health, and serves as a health specialist at UNICEF Tanzania, has 14 years of experience in both public, private sectors, and he leads health systems strengthening projects focusing on reproductive, maternal, neonatal, child, and adolescent health, HIV/AIDS, gender integration, and emergency preparedness. Dr. Mwandalima expertise include program design, implementation, evaluation, and national guidelines and policies in reproductive, maternal, neonatal, child, and adolescent health. Last, and the youngest, is Dr. Anab Issa. Dr. Anab is a medical doctor and an early career researcher. She currently works at Muhimbili University of Health and Allied Sciences, project coordinator for the EECC in Tanzania. She graduated from MUHAS, where he has been involved in clinical and public health research. He has 3 years of experience in various initiatives. She has contributed to the programs, especially on facilitating training and volunteering work. She's a member of the Royal School of Tropical Medicine and Hygiene and the global ECC network. Karibu sana, Dr. Anab. Now, in this panel discussion, we are going to start with 20 minutes for the keynote speech, which will be followed by panel discussants, which they are going to spend only 5 minutes, and I want to insist 5 minutes. And then we shall have 10 minutes of questions and answers from the audience. And then lastly, we are going to close our session. May I take this opportunity to welcome Dr. Karima Khalid for the keynote speech. Karibu.
Thank you so much, Professor Pembe, for those very kind words. He's also my PhD supervisor, so if I do well in this work, I make him proud, so I really have to perform. Thank you for giving me this opportunity to speak to you on the essential emergency and critical care, an intervention that we believe, if implemented and implemented properly, has the potential of saving up to 1 million lives annually. And we as Tanzanians are proudly the first country who has really done a lot of work in EECC. It's a global initiative, but in Tanzania, a lot has been done, and we have really moved forward in the EECC framework. We are currently in the stage of implementing EECC in our health facilities. And we're calling that program of ours Essential Emergency and Critical Care in Tanzania. But to start with, for us to understand what this initiative is all about, I'd like to take us back to our clinical settings. A lot of us here are still working clinically or have worked clinically at some points of our lives, maybe now are more involved in higher areas of policy making and the like. But let's take ourselves back to the wards where we have been working for many years or for a few years. So I'll take us through some cases. And case number 1 is a mother who is 40 weeks pregnant. She arrives at a health facility unconscious with a seizure. And we diagnose her as having eclampsia. Emergency C-section is done, and a healthy baby is delivered, and she's sent to the ward. And eagerly you will go in the morning to find out how your patient is doing, and you're told, unfortunately, the patient passed away overnight. Another case is of a motorcycle driver who is age 25. He has a road traffic accident, and he arrives at the emergency department covered in blood. And we diagnose him as having polytrauma. We do a CT scan, we do the necessary surgeries, and then we send him to the ward postoperatively. Again, a young ANAP goes to the ward the next day to find out how her patient is doing, and she's told, unfortunately, your patient passed away overnight. And our third case is a 2-year-old boy who arrives to a health facility subconscious with a high fever, admitted to the pediatric ward. Again, we come the next day and we find that our patient is lost. So all these cases are not made up. These are cases that happen in our health facilities. And I think if we can relate, most of us or all of us have been faced by these situations in our careers. And they can be quite frustrating for us and also for our patients. So what do you think these patients died? Why did they die? We saw that all of them had the correct diagnosis. We diagnosed them as having eclampsia, having malaria or polytrauma, and the right treatment was given. So the diagnosis was correct, and they were given the correct treatment. But, or maybe, we don't know for sure, but maybe most probably that was the case. But then what could have gone wrong overnight? So could it be lack of EECC? Is it that maybe these patients became critically ill and deteriorated overnight, and they were not identified in the wards as being critical, and also they were not given the fundamental, most basic care that will keep them alive so that they can survive that stage of critical illness and further treatment can go on in their lives? So to understand this better, we have to understand what critical illness is all about. So what is critical illness? This is a state of ill health with vital organ dysfunction. There's a high risk of imminent death if care is not provided to these patients, and there's a potential for reversibility. So if care is provided, these patients' lives can be saved and their state can be reversed. And this diagram that I'm showing over here looks at illness severity as a way of looking at patients. Yesterday, I was listening to Dr. Grace, and she was talking about community health workers taking the horizontal approach and being integrated in all the systems. So here we're talking about now disease or illness severity. So normally what we do is we classify our patients into specialties like infectious diseases, maternal conditions, surgery, trauma, pediatrics, and the like. So you work in these vertical systems which are diagnosis-based. But all these patients at a certain point might or will develop critical or become critically ill. And when they become critically ill, what they present with is equal or is the same for all these, irrespective of their condition or their age or their diagnosis. So we classify critical illness as that stage when these people have become very, very sick. So how common is this? Is this something that we should be talking about? Why is it so important? So we see that in the world or globally, we do not have very good data that tells us exactly the number of people who are critically ill at a certain point. But there are several studies that show us that there's a high burden. For example, we have 45 million adult critical illness cases annually, and 11 million annual deaths occur due to sepsis. And 1 out of 10 patients in the emergency units are critically ill. This was a study done at Muhimbili. And 1 or 2 of 10 patients in wards are usually seen to be critically ill. This is around 20% of the patients. So do they die? Why is it important? So the mortality rate is really high. They have a high mortality of around 21 to 82% in different studies. And what we all normally think of, when we think of critically ill patients, we think of them being in ICUs, right? So when you see critical illness, ICU. So we usually think that these patients should be or are in ICUs. But studies that have been done, both in lower and high income countries, have shown that more than 90% of critically ill patients are actually in our wards, our general wards, and they're not located in ICUs or HDUs. So these are the patients that we take care of every day in our wards where we are working. And we see that there's a large unmet need of care for these critically ill patients. So a study that was done in Malawi showed that 90% of patients who have been diagnosed to be hypoxic, so widespread lack of fluid, showed that only 58% of beds were in hospitals with an oxygen supply. So the other beds were in hospitals where there is no oxygen in those facilities. So that from this we can see that this is such a large unmet need of provision of critical care. And this is so because these critically ill patients fall between initiatives of care that we are doing in our everyday work. So we have these interventions like for medical specialties like emergency medicine or obstetric or pediatric and the like. And we also do research which is based on these silos. So patients fall between these silos of care, and that these critically ill patients fall between these silos of care, and they're not actually talked about when we're addressing this. When you're addressing patients in these silos. And then we also have a lack of unified approach for managing our critically ill patients. So the EACC concept came about because of, to see how we can address this gap. So it's a system innovation, and it defines that it is the care that all critically ill patients should receive in all hospitals in the world, irrespective of their age, of their diagnosis, or their location in a health facility. It specifies the minimum standards of care that are required in critical illness. And how complex is it and how costly is EACC? So when you look at this pyramid, we see that, as we talked before, these critically ill patients can be or are seen in all parts of our facilities, so from emergency unit, operating theater, ICU, and our wards. So with essential emergency and critical care, we are able to cover most of these patients with a very low cost. So in this regard, we are talking of population effect, population impact, which is more important because we're going to be, if we implement EACC, we are going to be touching a large population of our people. And as you go higher, we have the intermediate emergency and critical care, which now has things like CPAP and vasopressors, and advanced emergency and critical care, which now we are talking of the place where I work, actually, the ICU and the theaters where we intubate patients, we do mechanical ventilation, ECMOs, and renal replacement therapy. So this number of patients who actually require this care are very few compared to the many patients that actually require EACC, which is the most basic things like airway management, oxygen, IV fluids, who are many, and we can, if we really make sure this happens properly, then we will be able to save many patients at a very low cost. So for us after coming up with the concept, we needed to define the contents of what EACC is. And a consensus study was done, Delphi consensus, and it involved 269 clinical experts from all levels of income, from lower to high income countries, clinical expertise from all cadres and all specialties, from emergency care, intensive care, medicine, surgery, pediatrics, obstetric, nursing, doctors and specialists. And with this, after this Delphi consensus study, we came up with clinical processes, which were 40 clinical processes and 66 readiness requirements. These clinical processes were in the identification arm. Now we need to identify the patients and then provide them with the care that they need. And these identification things are just things like triaging the patients, doing their vitals, working with their ABCs, and then providing the care that is needed. And these are things like IV fluids, oxygen, and the like. And things like blood transfusion, CPAP, did not make it as the most basic care. So these were seen as an intermediate level of care. And we needed 66 hospital readiness requirements. And these are things like equipment, consumables, HR, human resource, drugs, routines, guidelines, and infrastructure. We classified them into 8 categories. And these are things like pulse oximeters, BP machine, IV fluids, oxygen, and the like. And people or human resource who can identify that a patient is very sick and give that kind of treatment. So does implementing this really improve outcomes? So we are going to do a larger implementation work with this project, but what was done before us, a small study that was done in Muhimbili at our ICU, this was done at an ICU level, showed that implementing this type of care, whereby you just look at you identify the patient, and then you are capacitated to give some sort of intervention, which can be done by anybody who is taking care of the patient in the facility. The nurse, the doctor, it doesn't matter if you're a specialist or not. And this study showed that after implementing the VSDT chart, acute treatment of danger signs increased from 23% to 73%. And mortality for hypertension went down from 92% to 69%. So from this, you can see that implementing EECC has the potential of working and saving people's lives. So we did some studies in Tanzania to see what our state is currently when it comes to EECC. And we found that the readiness requirements that I talked about, the 66 requirements, we looked at 5 facilities of different levels in Tanzania, and we went in depth and into each and every ward in those facilities to find out if these readiness requirements are available in those facilities, and they are working, and they are they are available in the right quantities. So what we found out is that at the hospital level, 85% of these requirements are actually available in the facilities. But when we went to the ward level, this percentage went down from 85 to 57%. And this is because the requirements were not there in the ward when the patients need them to be taken care of. So for example, if a patient becomes hypoxic, there might be oxygen in the facility, but it's in Ward A and I'm in Ward C. And if a pulse oximeter is needed to check his saturation level because he's struggling to breathe, it has been locked by the in charge somewhere because it was getting lost, or the batteries are not working. So the readiness went down from 85 to 57%. We also assessed readiness or availability of resources for advanced critical care, and we found that only 31% of those resources were available in our facilities, which makes it very hard to upscale advanced critical care, especially considering that even most of our initiatives. But we can see that from all the talks that we've had so far, training alone cannot improve the care that we're providing to our patients. Because once we train a person, take them to an environment that is not enabling, they will not be able to use the knowledge that they have been given, and that actually will make them even more frustrated because now they know what to do, but they're not able to do it. And procurement of equipment, the same thing. If you have those equipment, but we see a lot of them lying in our facilities and then they're not functional, or the other things that are needed around that are not provided in the facilities. So what are the benefits of programs focusing on EECC? So it's a low-cost and cost-effective approach for a huge quality gap, and no patient is left behind. So it cuts across all cadres and all kinds of patients. There's increased preparedness and resilience. If we can implement this, our public health, we will be able to tackle public health emergencies. Our systems will be more resilient to do so. And there will also be improved care and outcomes of critically ill patients in our primary health care and our general wards. And since we are upscaling our EMDs and ICUs, we need to capitalize on and prevent this huge investment that is being done by our government currently. And for these initiatives to work best, we need to make sure our wards are working well, so that if I have a patient in the ward that I can really actually help with just giving oxygen, I don't need to take that patient to an ICU. And for me, who is working in an ICU, when I've extubated my patient, I'll be comfortable to send this patient back to the ward because I know the ward is good enough, it's going to provide the oxygen that this patient needs and keep them alive. So currently, the government of Tanzania, both Zanzibar and mainland, have developed strategic plans to implement EECC in all its healthcare facilities after being sensitized on what EECC is and what it can do. So now we have these strategic plans, by both governments. And in these plans, the goal is that all critically ill patients who need EECC get this care, and that we are going to create, the aim is to create an enabling environment for provision of quality EECC and strengthen the capacity of health systems for planning, management, and service delivery of EECC services, and increase access and utilization of quality EECC services. So currently, there is a plan of integrating EECC into the primary healthcare facilities in Tanzania, and this is planned by the government, facilitated by UNICEF with technical advice from us at MUHAS, and it is based on these national strategic plans that were developed in November 2023. This program is going to be an 18-month programming to scale all primary healthcare facilities, including dispensaries, health centers, and district hospitals will be involved. And there's also a possibility of including regional referral hospitals to make it even more comprehensive. And the aim is to avoid having a program which is vertical, and to embed this ECC into our existing health system and strengthen them and make them ready for emergencies. It's going to start, we're going to start doing this in 5 regions, which is Dar es Salaam, Mtwara, Songwe, Kigoma, Katavi, and also in Zanzibar. So as you can see in this map, these are the regions that you're going to start with. And the objective is to operationalize and integrate ECC, including oxygen therapy in health facilities in 5 regions of Tanzania, mainland, and Zanzibar. Our specific objectives, we have divided it into 3 pillars, and the first one is disseminating and developing disseminating the strategic plan, and this is one of the things that we're doing. Part of it is what we're doing today. So this dissemination is going to happen to all program managers, directors, RMOs, and DMOs, and we're going to develop modules for training and job aids to use as standalone or to be incorporated into other training modules. And we're going to revise our HMIS tools that we were just talking about previously to capture ECC indicators. Our second pillar is going to assess and roll out and implement and do some implementation and implementation research. So with that, we're going to assess, do a rapid assessment of all these facilities that are going to be involved. And then from those assessments, we're going to find where the gaps are. We're going to develop different implementation strategies. And then with those strategies, we are going to implement them and embed into them implementation research to find out which ones work best. Once we've done that, we go into our 3rd pillar, which is cost effectiveness analysis and ECC operational plan, and develop a cost-effective analysis of ECC implementation strategies, and come up with a 5-year operational plan for ECC. So our geographical scope, as I just stated before, covers those 5 regions in Zanzibar with 2 districts in each region. We are proposing that we cover 2 districts in each region. This can also be discussed selected with collaboration with the government, and the criteria for doing this may vary from variations in health system performance or health indicators, geographical location, size of the district, distance of the district from the referral center, and the coverage is the whole population in these selected districts, with our target being any person becoming critically ill in that population receiving ECC. So there's also possibility of including regional hospitals with support from the government and other stakeholders. So we divided these 3 pillars into 4 work packages, with the first one being government and stakeholder engagement and dissemination of what ECC is, the strategic plan, and what we are planning to do, and then developing capacity building and training materials, HMIS work package, and implementation research work package, and our final product will be the 5-year costed operational plan for ECC. We had an inception plan report of how this work is going to be, which details how this work is going to be done in the next 18 months. And the work of the work package 1 is to develop products and dissemination plans on how we are going to, who this information should be disseminated to at national and regional level, and also to continue engaging with the government throughout the 18 months to see how we are progressing and what needs to be changed and what needs to be removed or being added. And work package 2 will develop, they're going to review the existing pre- and in-service curricula and training material and other training initiatives, and they're going to develop capacity building approaches and training material. The 3rd work package, which is the HMIS, they're going to look at the platforms, the HMIS platforms that we have in that were all talked about today, and look at the support supervision and mentorship checklist, and identify any gaps that are there when it comes to ECC and what kind of indicators we can incorporate into this system, advise the government on that, and possibly incorporate them into the government system. The work package 4 will come up with, we will do the rapid assessments, come up with the different strategic implementation plans, come up with different implementation strategies, come up with also implementation research proposal, and we're going to integrate these implementations into the regions where we're going to be working in, different implementation strategies in different regions depending on what we see is missing, and at the end of the day, find out which works best, and then come up with the healthy, a costed operational scale-up plan for ECC in Tanzania, mainland, and Zanzibar. There are going to be several deliverables to make sure that this works. There are several steps that are going to be followed, and this is our timeline for the work, which is 18 months. For us to be able to work well with the government, to be able to support them, we needed steering groups, and in the mainland we already have our steering group formed with the Director of Creative Service, Minister of Health, Director of Health and Nutrition, Puralt, and Director of APRO, Minister of Health, Tanzania. Together, so we'll be working with them, with their focal people that they will appoint, together with ASET, MOHAS, and UNICEF to make sure that this work goes smoothly. And for Zanzibar, we are still under discussion with the Zanzibar government on who will be forming the steering committee. So we've already started the work package 1. These are our immediate next steps. We have started the work package 1, which is dissemination, and this is one of the platforms that we're using to inform everyone of what the government is planning to do in the next 18 months and beyond. And we are also starting to work on the implementation package. We're also working on the HMIS package already, so that we are moving forward with, together with the government and UNICEF to make sure that all the input are taken in, and whatever we come up with is what is agreed for by the government. So our slogan, we came up with a Swahili slogan for this, and it is Huduma muhimu na tiba okovu kwa wagonjwa mahututi, and our aim at the end of the day, our vision, as Anna B was telling us in the morning, where we should be able to film what you want to see at the end of whatever you're planning to implement. So our vision is to see that all patients are happy like this, receiving oxygen, receiving IV fluids, with a nurse or a doctor who is happily performing this work on their patients, and that we are saving more than 1 million lives annually by implementing ECC in all our health facilities. Thank you very much. I will end up here.
Thank you very much, Dr. Karima, for that presentation. You have spent exactly 20 minutes as planned. Now, the most important takeaway is this essential emergency and critical care to be available to anyone who needs it, because it can occur at any time. Now, let's go to the next part of this. Now it's a panel discussion. We have heard about EECC, EECCIT, what we call ECT, and we have heard that there are strategies which have been developed by the Ministry of Health of Tanzania and the Zanzibar in order to provide these ECC services. Now, may I ask Dr. Silvanus, what are the aims and the key components of strategies of which they have been developed for the EECC in Tanzania? Please.
Thank you. Thank you very much, Prof. and our moderator. Thank you, Karima, for a very nice presentation. It really is a very important concept to start thinking about it, but also to implement it in our healthcare facilities. You already said our neighbor among 100 patients that they have that need oxygen, only 10 of them would receive it. That's really terrifying. And in our country as well, during the COVID-19, we were surprised by the pandemic to search ourselves and see how lacking we were in terms of critical care and emergency care. We learned that we really need to expand our oxygen production and oxygen access, and even the cost. We learned that our facilities need to be able to take care of patients that are critically ill, because some of them were having these other normal diseases like diabetes, hypertension, malaria, and they couldn't get that care that they needed. And in that study that was done, the assessments that have been done by our local experts, local scientists in Tanzania, and even the global experts on this issue, they've learned, in particular in our settings, you said very well, like 85% of the resources that are required are available for the essential, emergency, and the critical care. That means for us to start doing this, we don't need much, it's just to start. We have all the resources that are required. And what are those resources? Those were very simple resources for us to take care of a critical care patient of any kind, being a delivering woman, a under 5 child, motor traffic accident, stroke patient, heart disease. We just need the basic things to save their lives. We need, first of all, take vital signs. Having a blood pressure, that's a simple requirement. Having a monitor or pulse oximeter, having a giving set, the cannulas, the thermometers, those are the basic things that can change the outcome of our patients. And it was seen we have the 95 or 85% of our facilities have all those things. But the readiness was a challenge. When you want that BP machine, it is out of charge. It is there, but it was not on the power. Or the cable is not around. At least those are the main challenges. We were not ready to provide care, though the resources were available. We had doctors, as we said very well, but when you want that doctor, he's home. You have to call them to come. So those are the challenges. Now we put forward the strategy. First of all, we started with the infrastructure part to enhance the gaps that we still had. The oxygen production, we increased it to, our oxygen plants have been taken from not only the tertiary hospitals, but also in primary health facilities. We have around 21 now in our district hospitals that can provide oxygen. Number two, we made sure that our emergency departments that receive first these patients would have this basic equipment. So we construct, as the government, as the health sector, we have constructed in the primary health care more than 83 now emergency departments. And there were around all regional referral hospitals have emergency departments. Our specialized hospitals, zonal hospitals, and national hospital, we have those. And we have also constructed ICUs, around 28 in the primary health care. So for us, we have put again the resources, to contribute to the care that we would need, the essential emergency and the critical care. And now we said we would put forward now the strategic plan to address the gaps and roll out the ECC services in all health facilities. The aim is to ensure there is high quality services and to optimize the survival of our patients. Because it doesn't need much. It doesn't need masters. It doesn't need all of us to have degrees of medicine, for us to take care of these patients. So we want to create the enabling environment through that strategy. It shows how we can enable our environment in policy, in leadership and governance, There's a writer of the book called 4 Disciplines of Execution. He says there's no problem in planning, having the strategies. The issue is execution, realizing the plans that you have put forward. Our leaders in our primary health facilities, in our tertiary health facilities, need to find the science and art of implementing, executing the plans that we put forward. We want to strengthen our capacity of healthcare workers and the system in general, in planning, management, and even in the delivery of our care for our patients. In that strategy, we have also involved or put forward the strategy to involve the community, to learn that we have that capacity in all levels. And if we have very critical care patients, send them to our last one was to provide the national guidance. This strategic plan provides the guidance, like a national guidance in essential emergency and the critical care, through the simple principles, the integration of this service in every ward, in every area of care. The critical care is not only at the ICU. This care we are talking about, the essential emergency and the critical care, has to be provided everywhere where the patient is. That's where we can make a difference. Two is the equity, give it a standard to everybody. If you do it to every kind of patient, we're going to save lives. You said 11 people would die because who are critically ill. 11 million people die every year. And we said if we do these basic things, we are going to save more than 1 million lives. Just doing these basic things. Things in strategy that are there, accountability and effective intervention of every bit of the simple things that we are emphasizing. The 169 things you mentioned, and the first ones were 67, you remember? There were just 67, the basic ones. Because of COVID, we said we could add this, we could add this, we could add this. Now there are many, but all of them are basic. So we need our people to start using them because they are low cost and they are of low complexity. Maybe I will end there. Thank you very much.
Thank you very much, Dr. Silvanus, for that. And that is so important. We have to save those patients who get critical illness, and the services to be, what we say, they have to be equity in provision of services so that it's available to everyone regardless of the other factors which you have. Now, I'm going to the second panelist, Dr. Albert. You have been working as a clinician for 14 years, and working especially in obstetric gynecology. There are so many issues which are related to the quality of care. Now, from us, we want to know what will be the challenges in quality of care that ECC will face during its implementation, please.
Thank you, Mr. Moderator, Professor. It's really a pleasure to be here and contribute to this panel. So EECC really will help with the quality of care, especially in primary health care facilities. We have all seen the government's commitment and all partners' commitment in improving healthcare services at primary health center. And we still see the challenges in quality of care. From obstetric and gynecology, we have learned that providing basic and life-saving care is quite important. So we have several processes that once you see these life-saving conditions, there are things you can do, and we have seen the outcomes being improved. This has not translated in general practice, where a patient coming to an OPD who is critically ill doesn't receive this life-saving care. We have seen several gaps in quality of care, especially in terms of hospital readiness or facility readiness in providing critical care for critically ill patient facilities to deal with critically ill patients. So what we see that EECC will provide, or an advantage for EECC to act on, is on improving quality by, one, investing in healthcare providers. One pillar of healthcare services, quality healthcare services, is having healthcare providers who are competent, skilled and trained, motivated and updated in the right services. And we know we have shortages of healthcare providers, we have unevenly distributed healthcare providers, but also those who are available are not really skilled to provide essential critical care to critically ill patients. So one thing is to make sure that these providers who are there at the front lines are capacitated by being trained, by having the skills, by having the right attitudes, but also making whatever, all these trainings and good things that they have into behaviors, that whatever they are being, or whatever EECC is bringing up should be taken up as a behavior, changing behaviors to be able to practice and give quality care to critically ill patients. Another thing is that to empower healthcare providers as frontliners to be able to work within their facilities to make sure their facilities are ready at all times to provide essential and critical care to patients who require critical care at all times. And this is the main, I think, what EECC is bringing to improving quality of care in primary healthcare facilities, and that by doing this, we are going to make sure that all critically ill patients receive essential critical care at all times, at all levels, irrespective of the times that they're getting there. I think by doing this, we are going to reduce tremendously the amount or the burden of patients who are critically ill, who will require advanced therapies, who will require ICU admissions, who will require life support, and that by doing this, we are going to reduce the amount of referrals and the amount of patients requiring more care and more resources in terms of human resource and also additional resources. What is so nice about EECC is that it cuts across all levels, it cuts across all professions, it cuts across all medical specialties. A patient who comes to emergency because of stroke will have essential critical care for him, and a patient who comes to emergency obstetrics for obstetric bleeding or a neonate with sepsis will have what they require at that point by health providers who are skilled and who know how to use their environment to save those patients the best way they can. Thank you.
Thank you very much, Dr. Fadrun. That is so critical that we have to invest first, but secondly, we have to look to the providers, their knowledge, their skills, and their attitude. But on top of that, they are motivated. What type of motivation? There's another discussion. Is not in this room. Now, let's go to Dr. Kyungu. Dr. Kyungu, you have heard about the need, importance, and how essential emergency and critical care can save life. Now, looking at EECC, how is it going to strengthen the services within the primary healthcare facilities? Please.
Issues where, as far as primary healthcare is concerned. Ladies and gentlemen, as we know, primary healthcare system accounts for more than 90% of our systems here. So we have a lot of facilities down at the dispensary level, health center, as well as district hospitals, which serve as the primary level of referral in the country. We understand that if these facilities, if the whole fleet of these facilities is well equipped in terms of people, in terms of resources, then the secondary level as well as the tertiary level might have not much to carry, not much load to carry, and then we can be able to save a lot of lives. So the primary level actually poses as the prime area or the prime level where we can save all lives, which for us, they seem to be preventable. for deaths, all of this which occur are preventable. Ladies and gentlemen, EECC is very important at the level of primary health care. They had a lot of challenges which we faced previously, and the occurrence of COVID-19 actually augmented, it exposed us to a greater extent. That, first of all, issues about limited resources in terms of human resource, not only human resource, but also skills among those human resources we have. The attitude, as Dr. you said here, that people are there, they are skilled, but how is the attitude to manage or to face or to handle people who are critically ill or need critical care? So those are the issues which we faced. I remember when I was working there at the primary healthcare level, issue of oxygen was a serious issue. And during the pandemic of COVID-19, we lost lives, only because we lacked supply or adequate supply or supply chain all the way down to the dispensary level or to the health center level. And I remember during those times, the SOA supplier was Tanzania Oxygen Limited, which was in Dar es Salaam. So all of us had to travel to Dar es Salaam to collect oxygen, let alone the availability of oxygen tanks or those oxygen gas tanks with availability at the health facility. Now, you might find also at the primary health care level, other resources which are needed to support the critical care are also missing. And you might find other sectors also have those facilities, have those resources. But how is the multi-sectoral collaboration at that level? Again, we found it as one of the challenge for us. So coming back to the need or the importance of EECC in primary health care level, it's very important, as I said before, because it should be provided to all critically ill patients of all ages in all health facilities, which means if we have 90% of health facilities, there should at least a considerable number should be able to provide these services at that level. In this case, they should be able to triage, to early detect those who are critically ill or those who are prone to critical illnesses. And this also needs now the need of investing in skills among our staff to be able to detect early, to make sure that they triage, they make the correct, adequate triaging of these cases, and secondly, to provide the appropriate care or appropriate treatment to these critical ill patients or those who are prone to that. And doing this, we can be able to save a lot of lives. But at primary healthcare level, one of the important matter which we try to make sure that it is emphasized is the costs. We understand that the lower levels, the costs must be as minimal as possible. Let alone that we are providing quality care, let alone that we are providing effective treatment to the clients who are needing, but it should be at minimal cost as possible. But again, we shall be able to be available to all clients who visit these health facilities. Ladies and gentlemen, issue for accessibility is very important. As you understand that we have all that span of healthcare facilities, we have more than 170 district councils, hospitals, we have more than 500 health centers and thousands of dispensaries. All of this, we are trying to make sure that they are built so that the community can be able to access them, the services readily. My friends have talked so much about the investment the government has done in ensuring that we have this primary healthcare level invested with capable of providing these services. For example, like availability or expansion of ICU services, to about 28 facilities, and EMD, about 83 EMDs at the district level. All these are there to ensure that these services are provided as effectively and at quality needed as possible, without entering other costs of referring these cases or these clients to either secondary or tertiary level. As our first presenters has shown, that there are cases which reach at that level, but if we could have done something at the primary level, we could have prevented those deaths and those morbidities or reversible complications which arose. So, ladies and gentlemen, we at primary health level, we have this system also operates at community level. And now we are working towards ensuring that we have capable community-based health services, which has been inaugurated recently, and now we are working on its operational guidelines. But the involvement of community health workers is also important, that we are trying to equip them so that they can be able, even at the community level, not only to give education, but also to detect those common preventable diseases which can run very quickly or can lead to a critical illness at community level, either to direct the clients to come to the facilities or to provide the basic corrective services, of which is part of the package in provision of the services at community level. We are trying to make sure that the services or the...
I'm sure it's the last one.
Yes.
Please.
Yeah?
Proceed, the last one.
Okay. We are trying to see if we can be able to put the multi-sectoral collaboration component, which is very important at the primary healthcare level. The government by itself cannot carry the whole burden of taking care of or providing these essential emergency clinical care services, but with the involvement or collaboration with the private sectors, faith-based organizations, facilities or organizations, or other sectors determinant to health, we can be able to work together and also reduce the cost, but provide the most effective or critical services at the community or at the primary healthcare level. Of course, this is going to also complement with other services as our fellows, but it's also going to complement the current existing system of which it entails or manages the health system.
Thank you very much, Dr. Kyumbu. Just in summary, the most important which I has picked to strengthen the primary healthcare level is that you may increase the competencies of the providers, but as well as the availability and supplies and equipment, but more importantly, availability of resources. And decreasing the costs, because when you are providing EECC, you protect these individuals from going for the need for advanced and the intermediate emergency care among them. Thank you so much for that. Now I go to Dr. Mwandamila. We have heard there will be a concept of implementation science. Most of us, we know most interventions which are done, they don't have implementation research in it. Now, why is this so important step? Implementation science in EECC IT. Karim.
Good evening, ladies and gentlemen. Good evening, ladies and gentlemen.
Good evening.
Okay, I just want to know that you guys are listening. So thank you very much, and thank you to the previous speakers. I think most of the things have been already shared by the previous speakers. So coming now to the question, Professor, that you've asked me about why implementation research. So basically, we feel like, as UNICEF and government, because we work very closely with the government in mainland and Zanzibar as well, we find this to be a very ambitious undertaking, because I think we have heard what Dr. Erasto was saying here. The vision is to integrate ECC in all service delivery point at point of care, at health facility level. So that is not very easy, and I remember even in the first day, There are a lot of discussion about integration, why it's not working, you know, vertical program, horizontal programs. So, and again, most of the things that have been shared by my colleagues as well, it feels like, you know, the country, you know, has almost everything to offer ECC. But why is not happening? So also taking back now to the presentation that was delivered today in the morning, I think Dr. Anna Bergstrom did answer this question already in the morning in one way or another. So because we understand most of these evidence-based interventions, you know, proven interventions, high promising interventions, when they're implemented, you know, in a real-world settings, not all of them, they lead to a successful result. And this is one of the example. You know, ECC is there. It's not like we don't have the capacity, but the cost involved for provision of ECC services also is very low. But why the facilities do not have the capacity to offer these services? So we thought it is very critical to embed an implementation research piece in this kind of work, so that we collaboratively, the managers in the regions where this program will be implemented, the decision makers, RMOs, DMOs, people who understand the context. So we are going to actually design together with people who understand, the context where this ECC program will be implemented. Because one of the difficult things that managers struggle to disentangle is when, of course, they are taking these innovations to a real-world setting, is understanding the factors that, can influence the success of these interventions, And in the morning, Dr. Anna, shared some of those, for example, behavior, leadership, management, climate, a lot of things. So that's why you'll find, an intervention, same intervention, is being translated, somewhere, differently when you compare to another place. And even the results also are reflected. This was also shared by one of the speakers yesterday as well. So we felt that this is very important to embed an implementation research so that to give us, implementers and the government, a platform to learn, on what works where. And to achieve this, we've selected a number of regions which give us, very good variability in terms of context, like Dar es Salaam, which is an essentially urban region. We've included also Katavi, which is a very rural region, and other regions among the 5 that have been shared, so that it can enhance our understanding on what works where to inform the government in scaling up this intervention nationwide. And you have seen in the presentation delivered by my colleague, Dr. Karima, that this work is going to culminate into cost effectiveness analysis. So we are going to design implementation strategies, and these implementation strategies are going to be costed, to inform what will it cost the government to scale up this intervention. And last thing, Professor, I see that you are looking at me keenly. Thank you. So lastly, so UNICEF has been working closely with the government of Tanzania. And the intention also is to support the government of Tanzania to have this capacity in implementation research, so that we can have this capacity in country and be able to address most of the challenges that we are facing when we are taking different innovation to scale. Thank you very much.
Thank you very much, Madam Miller. Really, I remember Ulrika Becker, the first time the lecture on implementation science, when she said, implementation research is the same as fixing the plane while you are flying. Therefore, the implementation research will provide views of all stakeholders, and those views will be incorporated during implementation to avoid other barriers to occur during the process. That's what. Thank you very much, Dr. Mohamed Amila. Now, the last one, Dr. Issa. We know you are a coordinator of this program in Tanzania. And we want to hear from you what are next steps in 4 minutes.
Thank you so much, Prof. The next steps have already been covered, but as a recap, as previously stated, ECC in Tanzania is a program that is to take place for over a period of 18 months. And we are currently in the middle of stakeholder engagement in dissemination of the National Strategic Plan for ECC and relevant guidelines in Tanzania mainland and Zanzibar. And in close collaboration with the regional authorities, we will organize dissemination meetings in the 5 selected regions that are Mtwara, Katavi, Kigoma, Songwe, Dar es Salaam, and Zanzibar. We will also develop capacity building materials for in-service training of primary healthcare cadres. This will be done after reviewing existing capacity building materials to assess the coverage of ECC content. And after this, we will develop training materials and other capacity building resources, some of which will build on existing curricula. In addition, we will review the health management information system and other platforms such as supportive supervision and mentorship checklists for identification of the available indicators for ECC. And we'll propose a list of additional indicators where needed and work with relevant authorities in integrating this into the health management information system. And the major work will be implementation of ECC into health facilities. In the health facilities of the 2 districts which have been selected, in implementation of the health facilities in the 2 districts which will be selected from the 5 regions. And this approximates to around 1,000 for health facilities. So we will conduct rapid assessment of these facilities, checking their readiness and health workers' capacity to provide ECC, and we will develop implementation strategies that are contextually appropriate for rollout and integration of ECC. And as ECC is implemented, we will perform implementation research to generate evidence on feasibility, adoptability, and effectiveness of these strategies. And finally, a cost-effectiveness analysis will be done, and a costed national scale-up plan will be developed for ECC in health facilities in Tanzania mainland and Zanzibar, so that there is effective, feasible, and universal care of all critically ill patients. Thank you so much.
Thank you very much, Dr. Issa, for that very summarized form, and we will spend your 4 minutes. Now, colleagues on the floor, this is the time, if you have any comment, a question to the keynote speaker and the panelists. I need 4 questions from the floor. One hand there from the lady, gentleman. The second one from this side. The third one from this side. No. Okay, we start with these 3. Madam, please. Just introduce yourself.
You need my introduction.
Yes, just your name and
my name is Dr. Anna.
Thank you.
Niko nyumbani. I have 2. One is maybe a comment. Thanks for the presentation. From your presentation, what I see is missing element, accountability and the leadership. The government, pengine kwenye hizo district mlizo select, vifaa vipo. Kwa mfano, watoto wamekufa, watu wamekufa. You had from 87 ya vifaa vipo, 85 to 57. Then unapoenda kuangalia, havina battery, havina nani. What is the problem? What is the problem? Ni capacity building, ni training, ni financing. Na wale ambao wamesababisha hivyo wamefanyiwa nini? It will keep on. Ya pili, the program is good, but it is only 18 months. And if you see what you are going to do, mainly it will end into capacity building, developing materials, because it will take long time and it will take all your money. So when you come to implementation, you will be having very little money to support the district, to involve your pure interventions, so that activities zile zinachukuliwa baadaye. But because it is a project,
thank you very much.
Something, we will just staying at the end of the year, you will come here and present good and best results ambazo zitakuwa si kweli. Thank you.
Ladies and gentlemen, let's be short and clear so that we can move forward. Please, can you introduce yourself?
I'm Dr. Mtei, short and clear. Critical care is not only needed in health facilities. What are we doing about critical care outside the health facilities? An accident has occurred, the rescue team, the traffic police, the ambulance services, and so forth. The numbers are there, but these numbers are for the ambulances to go and pick patients from the facilities to the facilities, and thereafter from the facility A to a higher facility. In between and before, what are we doing about it?
Thank you very much for that. The third one had been here, please.
Of course, he has emptied me about the strengthening of a referral system, because the emergency critical does not need only the availability of those equipment or competent, but a stable referral system, whereby we should have an ambulance which is equipped, timely management, and the infrastructure from moving from one place to another. Because like Dar es Salaam, you know, from Tegeta to Muhimbili, there is, you need to have to road traffic. It's an issue. Now, how can you tell us now only the presence of being equipped, having the cannula, whatever, that will really improve the critical care cases in such a situation?
Thank you very much.
Thank you.
Although you are not in the list, but can you tell us your name? The introduction is important.
Dr. Omar Mwangaza, Clinic Service from Kidondon.
Thank you so much. Then the last lady here.
Thank you. I congratulate all the presenters. My name is Jocelyn from Piorat. I just want to know what guided you in selecting those 5 regions. And you have selected 2 districts in each of the regions. Why couldn't you concentrate in at least 2 regions and cover all the districts in those regions? Thank you.
Thank you so much for that question and comment as well. Now, we go to the presenters. I'm providing you the keynote speaker. Should you have 4 minutes to respond to these questions, and then each panelist should have 2 minutes to conclude. Thank you.
Thank you very much for the very nice comments and questions. I will try to answer partly the questions from Dr. Anna, and then Isihaka will help me complete that. So for the project, planning for this project, for example, you talked about developing material and all that. All the steps have been costed, and for the development materials to the implementation strategies, they have all been costed carefully, and there will not be, we hope, no shortage of money because of the time. Because we have taken into consideration all the steps that need to be taken, and taken into consideration that some of these things that you're talking about have already been developed even before. We're just going to be adapting them to the context of Tanzania, and make sure that, and look at whatever we have in Tanzania. It's not like we are doing things from scratch. So we already have things that are already developed. So so it's not going to be like everything is going to be concentrated on that. Our main thing is the implementation part. Yeah. And for the critical illness being in the community too, and not only in the health facilities. So for this, we acknowledge that, and very much that is all over. But for this particular project now, we are concentrating on one thing, because you can't do everything at once. So when you have something, you concentrate on one level, and then if this one works well, then we can go to another level. And we have our colleagues from the ministry and from Puralj already talking about the community, so there might be other programs that are going to be addressing that area. And for our colleague who was talking about cannulas and things like that, those are not being the only thing that is needed. As we said, critical illness is There's a large burden, a high burden, but we are targeting these things that we can do to save at the 1 million patients that need this kind of services. So we know, or we have, this evidence has shown that if we implement ECC, we can save up to 1 million patients. So we know, we acknowledge that the referral systems have problems too, so we could also work together with the government and PRH to make sure that ECC is also available in our ambulances and things like that. So I think I will leave my colleagues to add more on to the... Thank you so much.
Please, Doctor.
Thank you very much for the questions and the first part of response to Diana and to Mtei, Dr. Mwangaza, Josephine for your contribution and questions. It is true, the part that was not mentioned is the key issue that is hindering the provision of essential emergency and critical care in our facilities, despite of having all these facilities in place, all this equipment and drugs and etc. Three things are very important in this case. One, people are they don't have clarity of what are their objectives when they are at work. To save lives, and what do you do to do that? What do you have around to do that? Clarity of that. People just come generally and move around. But if they are that focused, they can save lives. Number two is the commitment. It is missing in our facilities, and that's what we need to also advocate. Number three is the accountability. And this is a crucial part in the art of execution of things, the accountability. That's something that is our job now, everybody's job, every manager's job, every medical officer in charge's job, every doctor, every nurse, every lab practitioner, and every healthcare worker has to do to make sure we do that correctly. Number two, the question number two was about the critical care service starting out of a hospital. And fortunately, I'm the head of emergency medical services. Out of hospital emergency services is part of what we are doing. We are linking the out of hospital medical services and the health facilities. It's very important. We lose patients, a lot of them in the first hour of arrival or within 24 hours of arrival. That means the primary care was missing. The emergency care was missing. The out-of-hospital care was missing. And we lose patients from accidents, from secondary injuries. People are carried without proper cars, proper personnel. They are brought to the facility with already complications, bled out, etc. What we are going to do as a government, or as the Ministry of Health and PRH, we are now coordinating these ambulance services. We inaugurated the number 115. That is an emergency number. It is an emergency number to assist all the emergencies, health emergencies in the country. When you call, you'll be asked for Mama na Mtoto services, press 1. For accidents, press 2. So you press there, the ambulance will come to where you are. It will pick you. There will be trained personnel in the ambulance to start caring for you there to make sure you don't die with preventable death. So that's the plan that the government is making sure we are doing, because we have already bought ambulances. More than 603 are new ambulances put inside with the available ambulances that were here. We want to coordinate them, having the dispatch centers, having the paramedics. We don't have them formally yet, but we'll start in phases. The phase 1 will be using our healthcare workers who are available to run these ambulances in shifts. And then number 2, we'll be using our community health workers who are there to start doing, and the community groups like police, you said very well, the traffic, the fire and rescue teams, the other volunteer groups like Boda people, all those people. Even in our clubs like stadiums, etc., we do those training. Start caring before the ambulance comes so that the patient do not die. That is also a part of the essential emergency and the critical care. With that, I would like to thank you very much, Mr. Chairperson.
Thank you very much. Now, Dr.
Thank you. Just a minute. Thank you very much, previous speaker. I think he really wrapped it quite well. But my focus is intra-facility. So intra-facility, I really want to talk and talk about making providers and making clinical leaders. Clinical leaders will help providers to see the way forward. We want to change behaviors. Behavior change takes time. And behavior change somebody has to come it from within by seeing positive things from what they're doing every day. So that will take time. But we are in the right direction, we're taking the right steps, and I think we have, from all the presenters, we can get the sense of that. Thank you.
Thank you very much, Dr. Kyungu. 2 minutes.
Thank you, Mr. President. Thank you, ladies and gentlemen. As we understand that PRG is the implementer of all issues pertaining to healthcare service delivery, we are collaborating with the other sectors and the other fellows like Minister of Health. We have been working so much on EMS, as he said, and they are still working on it till now. And we are sure, and we are going to, we are sure that we are going to work together till the end to make sure that these services are established in those area critical or important areas which we have identified to start with and to roll out in subsequent phases. We are going to work more on the EEC management as far as system strengthening is concerned, issues about capacity building of staffing, of community members or other people who are key in the provision of these services, issues of resource allocation in terms of planning, inclusion of these activities or strategies into our CCHPs at council level as well as our plans, operational plans at regional levels. We are going to work on the issues of capital investment, continuing improving our infrastructures at health facilities, existing one, and also improving all those new ones. Issues about community involvement. As he said before, that the community-based health system is very important and crucial in ensuring that EEC is working as needed. Issues of multi-sectoral approach. As I said before, it is very important to include all other stakeholders are important in ensuring that these services are efficiently delivered. Issues about compatibility with other existing healthcare delivery systems, and there are issues of leadership and accountability, which is very, very, very important. With that, I thank you so much.
Thank you very much, Dr. Kyungu. I'm sure among the multisectorial, the Ministry of Education is there, and you are going to introduce EECC to the primary school curriculum. Oh, they are not there. Okay, thank you. Dr. Mondamila, can we?
Yeah, so thank you. Thank you very much,
2 minutes,
Professor.
Please.
Yes, so just to complement, I think most of the questions have been, effectively responded by my colleagues here. Just to emphasize, actually, there's going to be a co-creation process. So we are going to work jointly with the government at every stage of implementing this program. So just to mention also, I think like 3 weeks ago, we had a meeting with the steering committee for mainland, and we presented the thinking. This is just the thinking. So we presented to the Director of Curative Services, Director of Health Services and Nutrition from PRAG, and Director of Emergency and Response Services, the EPRU at the Ministry of Health. So this is going to be a co-creation process. I just wanted to emphasize that. But again, in other areas that have been asked by other colleagues, like, care outside the hospital, and currently the ministry is revising the guideline for community health worker, and there are ongoing discussions about, incorporating some of the basic things that community health worker can do, out of the hospitals, which are relevant to EECC. So that is something in discussion. And regarding leadership and accountability, again, UNICEF is working closely with the PRAG, as mentioned by my colleagues here. And currently, we're already piloting, some strategies to improve leadership and accountability in Kigoma region. Thank you. I think that's all that I was supposed to compliment.
Thank you very much, Dr. Mondamila. Now, Dr. Issa, 18 months. You have to talk. You have your 2 minutes. I'm protecting you. Why 18 months? That's the only you have to respond.
So 18 months is the plan for this program because all the steps and the work packages have been scheduled to have an allocated amount of time. And it is 18 months so that we allow for a longer term five-year scale-up plan. So this is it's a sort of a pilot, like fixing the bike while it's being driven. And then finally we'll have something that is more concrete for 5 years in the long term. Yes.
Thank you very much, Dr. Issa. My colleagues in this room, I won't say in the name of God, I'm sorry. My colleagues, we have heard about EECC as an essential component to save the life of the critical ill patients. According to the program up to now, it will be done in the facilities, but there are future plans that it can go to the community level. We know that we are not killing the patients, some other people, they may get a critical ill condition at any time. Therefore, it's good if people they know. Now, when you are getting out of this room, just remember EECC. And then remember ESIT. The most important we have to remember is that those who have critical illness due to dysfunction of the vital organs, imminent death, they need a care in order to reverse the condition immediately. This is the very, very important message. The other messages, the area, time, and what will follow slowly later on. I want to thank the panelists first for a very good discussion, the presentation which you had. On top of that, the keynote speaker, because it's not easy summarizing this in 20 minutes, and she managed it. And lastly, all of you who participated in this symposium. My name is Andrea Barnabas Pembe. I'm working with the Muhimbili University of Health and Allied Sciences, a physician gynecologist, but also a professor in inverted commas. Thank you so much. Now, before you leave this room, my friends, we have an announcement.
Good evening, everyone. So for those of us in the medical cadre, kama tuko katika tasnia ya utibabu, tunashauriwa au tunatangaziwa kwenda kwenye mabanda ya registration kwa ajili ya kukusanya CPD points. Okay? So those in the medical cadre, please go to the registration booth and claim your CPD points. The announcement to RMOs and DMOs on the NTDs, I believe you've all received them. And tomorrow we convene at 8 a.m. Thank you very much.
Okay, thank you very much for that announcement. We are coming to the end of this session.
Sorry, Chair. So we'll all convene here from 8. We have 2 sessions in the morning and then we'll go into parallel sessions. Kuanzia saa 2 asubuhi tunaanza hapa.
Asante sana. Now all the keynote speaker and the panelists, we should have a photo. Thank you and have a good evening.